So could you talk about kind of your background in your career field and how you got to where you're at now, and maybe a little bit about the job that you do now?
Sure. So this started a long time ago for me. It's been a journey. 98, I became an EMT and a volunteer fireman. I also worked in a level 1 trauma center in Virginia at the same time, so I had a lot of jobs, not a lot of free time. I got my paramedic in 2002, started working in Alaska in 2003 as a paramedic. And we had a couple of different levels there, so I moved up to the highest paramedic level there, which is, at my old service specifically, allowed us to do a lot more medically.
Yeah.
After that, I spent some time in California. I was a flight medic and then a ground medic working for different services. Came out to North Carolina in 2008, started working at Durham County EMS, which was at that time a pretty busy service, probably 3rd or 4th busiest in the state of North Carolina, and just a lot of different stuff going on there. During that time, I was able to be tasked with a tactical unit who did counter-narcotics and counter-terrorism work. A lot of like drug raids and high-risk warrants, and went to a bunch of courses that involved tactical medicine, which was something I'd always been interested in, but never really understood what it was about and what I was, what my role might be.
What is the difference between EMT, paramedic versus the tactical medicine side of it? Like, what's the main difference that you see?
So the EMT is basically BLS scope of practice. They can help people with basic airways. They can do CPR. They can work in AED. And they have a certain amount of knowledge that they get with that. Paramedic is a 2-year degree at this point, or it's at least a much longer certification, just depends state by state.
On top of EMT?
On top of it, yeah.
Right.
And some folks do an intermediate level in between. I never did that. I went from basic to medic. And there's a lot more anatomy and physiology involved, a lot more about how the systems function. There's a lot more invasive procedures, starting IVs, giving IV medications, putting tubes down for helping people breathe. And it's just a very big swath of information that you get as an EMT compared to not having anything. And then compared from EMT to paramedic, there's just a lot more depth. It's like an inch deep and a mile wide.
Right, yeah. So then from that, what's the distinguishing factor for tactical?
So for tactical medicine, what it does is it marries the BLS and the ALS, the advanced life support stuff, because there's a lot of things that you can do that are good medicine that are bad tactics.
Right.
There's some pretty famous bad situations out in the military where somebody goes to intubate, a physician goes to intubate somebody and pulls out a laryngoscope and turns the light on and gets shot in the face.
Right.
Because it's good medicine to secure somebody's airway, but it's bad tactics to turn on a bright white light in a covert environment, in a dark situation where you're trying to use light discipline. So it's knowing what to do when, and the Committee on Tactical Combat Casualty Care basically breaks it down in a couple of different stages to help us understand, like, all right, at these times when you might be getting shot at, these are the only things that you can do that are safe. And then after you get some cover, here's some things that you can do that are they're good for the patient, but also won't get you killed. And then as you move up, sort of the further away you get from the live fire situation, the more invasive the procedures get, the more advanced things get, and the less you're worried about getting gunned down, like right then.
Right. So the tactical medicine piece is not so much about addressing the different types of wounds, like the more likely to see, meaning gunshot and stabbing and stuff. It's more about the actual efficiency, tactical maneuvering while you're performing the procedure, right? Is there an emphasis on wound, like focusing on these wounds more so than just a basic paramedic?
We do a lot more stuff involving things like tourniquets, and we talk a lot more about wound packing. The thing that's been interesting is that, sadly, as there have been more and more active shooters, and the publicity over active shooter has increased, those things have become more mainstream as well. So, 8-9 years ago, nobody was talking about packing wounds just in general environments. Although we did in Alaska, that was a whole different level. But now a lot more of that is coming to pass. But things like packing wounds, how we're placing tourniquets in a low light environment, how we're able to do this under fire, what wounds we're packing, how to pack wounds underneath of somebody's gear, right? Like, if you're wearing body armor or I'm wearing body armor and one of us gets injured, that gear is what's also still protecting you, right? So very different than maybe going to somebody's house where they've been cut really badly. I'm gonna wanna secure that in a certain way, pack that wound, do all the things I need to do to it, and then get your ballistic back over top of it to protect you.
Yeah.
So a lot of it is like you said, it's marrying the tactics with the appropriate medical technique at that time. So it's a lot of learning how to move together, learning how to work within a team, and sort of understanding what that medical role is. And there's a lot of sports medicine and stuff involved in that as well. But the emphasis is wound packing, simple airway maneuvers, packing of wounds as well as tourniquets if you have to use those things together, but also how do I move a casualty from point A to point B, right? So we talk about the X being where you're under fire, where there's a problem. We talk about how do we get you away from that situation without us getting hurt. So we use things like nylon webbing to do halo strap maneuvers and basically throw it over them and you wrap it in different ways to be able to quickly evac or drag somebody out of a situation. So it's a mixture of all of those different things. But you're not going to see people, hopefully, starting IVs in like the care under fire stage. This is like putting in a tourniquet, quickly trying to pack a wound, rolling out, right?
Yeah.
So it really depends on how you read the scene.
Cool. And then, so what is your day-to-day operations like now as a flight paramedic, right?
So as a flight paramedic, it really depends call by call. We do a lot of interfacility transports of very, very sick people, like from an ICU where they might be on, somewhere between 3 and 12 infusions, keeping them alive and on a ventilator. And it's a lot more internal processes and a lot more thinking. And then on the other side of it, we go to bad trauma. So in that way, I'm still very involved with being able to practice in the trauma environment.
How does that go down? How does from the incident happening, how do you get the call? What's the procedure of you getting in the in the helicopter and getting there? Like, how does all that work?
So from the ambulance side of things, they will get a first responder, a fire truck or an ambulance. Somebody will go out to that scene. In some areas, we're auto dispatch. So if it sounds like a bad call when it comes in, they'll put a helicopter on standby or maybe put us in the air. From that point, we're going to get landing coordinates and information from the ambulance, basically. So they have to call us and ask. So in our area, it's not something where we would automatically get launched at the same time as an ambulance, whereas in the Midwest, you might do that if there's way more time that you have to travel.
Right.
So we get that call, and it'll come in the form of a weather check, and it basically says, are you good to go to even get off the ground? So they give us no medical information at that point, so that there is no influence on whether or not we should lift.
Right.
Right? Because early on in helicopter days, there was some concern about that. If they tell us it's a really sick little baby, everybody runs for the door every time. So instead, they ask the pilot, can you get off the ground with weather? Can you stay up to go from this point to this point? And it's either yay or nay. And after that, if it's a nay, we hear nothing, it can be tough sometimes when you know something's going on.
Right.
Sometimes they'll send us out by ground, but say the weather's good, we grab all of our gear, our equipment, strap on. A lot of us wear a chest rig or a vest of some kind. We fill our pockets with some of the stuff. We get we carry blood, so it's just packed red cells. And then if we're working at night, we'll grab our night vision goggles and strap all of our stuff on. And then we head out to the helicopter and do a series of walk-arounds to make sure everything's good to go.
Yeah.
And then after that, we do the series of electronic things, and off we go in the sky. And basically then we start talking to folks on the ground, and they bring us into an LZ, and we get down on the ground and start taking care of folks.
And then, so from the time you get the green light, how long does it take you guys to get prepped and on the bird?
A couple minutes.
And then what is, I know it's going to vary depending on where you're at, but what's an average response time for you guys once you're like, all right, boom, we're good, we're on, let's go?
Somewhere between 15 and 30 minutes. The area that I most commonly work in, sometimes they'll bring the patients directly to our pad, and so we'll meet them outside on deck. Pile will spin up, we'll get in the ambulance, do the things we need to do, bring them out, load them onto our stretcher, take them straight to the helicopter and out of there.
So if I can backtrack a little bit, so for the tactical side, you're being attached to LEO units, right? They're going to be doing specific missions and things like that, right? So then, can you first talk about how that goes down, in terms of like, okay, we're going to do a raid on this house for whatever, right? How does it work with you and them? What type of vehicle are you guys getting into? Like that type of stuff,
So I'll skip some stuff for OPSEC just
Right.
in terms of that, but in terms of, it's usually an investigation that's ongoing, and we were either tasked with the investigation or an investigatory unit has contacted us and said, we need you to come with us to go do this thing. So if we're going to go hit a house, for instance, we would do intel on who's coming in and out of the house, how are they moving, how many cars are there, what cars, are we seeing the same people over and over again. And I mean, everything using from Google Maps to any kind of computer software that the LEO guys might be using, we get as much information as we can. Are there children in the residence? Are there old folks in the residence? Are there animals in the residence? Because all of that helps us then prep for our side too. If there's a bunch of 18 to 25-year-old folks in the house, very different than maybe a couple of 18 to 25-year-olds, and maybe they're staying with grandma, and now you got a 60 or 70-year-old lady in the house who might get chest pain when a flashbang goes off. So it creates that sort of medical intel level as well. And from that point on, we get as much as we can, make sure all of the paperwork sides of things are done. LEO does their end as far as warrants and all that. And then we would get into whatever raid vehicle we were going to use, and we would enter into the area and basically use surprise and overwhelming force to...
Would you say you were more tasked with providing care for the people you were engaging, or for the officers and the people in the unit that was showing up?
So our mission was basically all care. So of course, first priority is going to be your team, because that's who you're tasked with.
Right.
Because there's in the areas that I was operating, there are also local ambulances that can come, or we'd have them on standby as well. So first due is basically for the team, and of course, but if there's somebody else there who needs help, we're going to help them.
Right.
And sometimes that's even the suspect. So you really have to be able to hold a dual role, right? You have to realize that your first course of action is best tactics. And after best tactics, it's best medicine. So I'm not going to put my team in danger to do a procedure, but at the same time, I took an oath to help people, so that's something that we would be doing. Knock on wood, I didn't really have guys get hurt very often. We did a good job on intel, and we did a good job of taking care of ourselves and of overwhelming the opposition. I took care of a lot of folks, chest pain, shortness of breath, stuff having to do with flashbangs, minor traumas. Knock on wood, there were not a lot of gunshots, not a lot of stabbings, and we had some people get cut, but a fair amount of blunt force trauma just from people getting knocked around, fist fights. Most of the gunshots that I took care of during my time in EMS were involved in being on the ambulance. It's really, it's a really good team that I worked with. Those guys were pros. But there's always that possibility.
Right.
And that's the thing about being in TACMED, is that you could do nothing 5, 6, 7, 8, 9 times, but you can't get lulled. You have to be ready at any point to help any range of person, right? Because if you're working in the civilian environment, you might have kids, you might have adults. So I dealt with a lot of shootings and stabbings out on the street, working in Durham and working out in California, and even actually a fair number in Alaska as well.
So before we move on to the next area, throughout your time, in all those different areas and coming up through, those EMT and paramedic channels, is there a day or a case, obviously not, for HIPAA, not mentioning a name, but is there a day or a case that you sticks out in your mind?
We did have a guy one time who was shot 7 or 8 times in his side, and then someone smashed his face in with a dumbbell.
Oof.
And he was in a bad way, and it took a lot of work to try to get him put back together. But there are a lot of those. They kind of
survived them?
He did not survive.
He did not.
He was in extremis from point one. But I've had some young kids have some severe trauma, some saves there. So
typically those shots from the lateral perspective are the more dangerous ones. I mean, getting shot is dangerous, but it's a more lethal entry wound, right?
It certainly can be a bad day. The things that you have to remember about doing any medicine is what does your assessment show you? Is there a lateral shot? He was shot all through here, right? So you think about entering in on the side, you know, of the lung here, tissue. You're coming towards the heart, great vessels, you know, innominate arteries. All these things are where they're located, and that's kind of how we're taught as paramedics is what's in there and what could be destroyed.
Is that more dangerous because, like, if you take something from anterior to posterior, it's less likely to hit as much critical anatomy versus from the lateral perspective, it can go through so much more?
Well, from the lateral perspective, what you get here is like there's no ribs, like up under here. Once you get into this section, once you're crossing into the armpits, there's less protection. I mean, you do have your rib cage does cross around, but there are open spaces, right? Also, if you're wearing body armor, there might not be as much side protection as there is front protection when we talk about plates and where different armor is located. And it depends on vest types, but
you could potentially, though, go through lung and then the arteries you're talking about, the spinal column and the heart all in one go, where typically if you're going to get an anterior to posterior, it's kind of going to be one of those, right?
It really depends on what the direction is. You know, there's a lot of misnomers about bullets going and bounce around everywhere all the time. They can. You can get bullet movement that hits bone and moves around throughout the body, but most of the time, if you can find point of wounding, you can kind of figure out the trajectory of it. Now, if it hits ribs, it could go. If it hits a big long bone, it could move. But
what about with 22? Is 22 more likely since it's just a lower capacity round?
You could find a lot of, like, there's arguments all over the web from every type of trauma doctor to shooter out there telling you, you know, what round does what when. And the bottom line is, if it goes in and doesn't meet much resistance, it's just going to tear a hole in whatever is kind of along its path.
Right.
And if it runs into things, it may bank off of it, which is basically bone.
Right.
You know, there's those old stories about hitmen shooting people in the back of the head and the bullet rounding around in the skull. I've seen a lot of x-rays of post shootings. I never saw anything that we were sure was that. But, you know, you find a bullet position and you can see where the damage has been, but you can't always figure out path of travel.
Right.
But a lot of times it's direct. You know, so what it really has to do with is, you know, how much mushrooming do you get from that round, and
which
how
would be the temporary and permanent cavitation of
so you
that
round. You get the mushrooming of the round. So whereas as it hits, it sort of the back of it sort of splits around it, and then as it's moving forward, there's the temporary cavitation. So it's pushing air ahead of it, basically pushing soft tissue out of the way. And then as that happens, there's also a shock wave, depending on how close you are, even from an edge weapon.
Right.
You can get that. You'll get a shock wave from that force as it's going in. So then there is tissue that's moved out of the way. Some of that cavitation will be what we call temporary, and some of it's permanent.
Temporary meaning that it had to pass through, that tissue will kind of go back in place, but there's going to be a permanent cavity where tissue damage is irreversible, right?
Yes, sir. Absolutely. Yeah. So you'll get that area where the shock wave pushed the tissue out, where that energy of that force, especially with rounds where it's going in that very small space, you'll get a lot of that. And then some of that will slough back together, which can make it very difficult on the outside also to see wounds.
Right.
A bunch of stabbings that I've been to, it's difficult to find the wound. You know, back in the day, people were stabbed a lot with ice picks, which I know kids probably are like, what's an ice pick for?
Right.
But if people were shaving ice with an ice pick, or they kept it on that bar cart, you know, or Swiss Army knives, because they're very thin. And so they'd go in, come out, the tissue comes back together.
You have internal bleeding, you don't see bleeding out much, and
they're bleeding to death, and you can't figure out.
I always remember too you telling me about what, like, you can pour hydrogen peroxide in the body, you see some bubbling, and then you're like, okay, let's focus on this area, right?
Mm-hmm. There are some tricks of the trade that you can use. Hydrogen peroxide is not great for pouring into tissue anymore. We know that it causes damage, but in terms of finding wounds, it's pretty awesome,
right?
Because it's going to bubble wherever you're finding, wherever that blood is. So you might have to use it, sweep across, pour it on there again, and just hope you can find that wound. Whereas with shootings, a lot of times
pretty evident.
You'll see something.
Yeah.
But I've had some cases where they're very small, like little teeny, like burnt black, just little holes, like dime-sized holes that you might miss on initial assessment if there's some clothes in the way or something's there. So much of it comes back to, you know, you come in and you talk to the patient, you just try to get a general impression of what their skin looks like, how are they reacting to you, are they able to move around and sit up? And then after that is, what do I see, what can I find with my hands? You know, if I'm blood sweeping, I like to use really light colored gloves.
Yeah.
You can see that they're black on the inside, so if they tear and you're in danger, you'll see like a black spot in the middle, but also...
Rather than having black tactical cool guy gloves, right?
Right, but then you can't tell, did the glove rip?
Yeah.
And if it's dark, I can at least see some staining on the gloves as I do my blood sweep. I can see like, oh, I got blood on my fingers when I swept right past this point in the back. I can roll them, turn them, do what I need to do to further investigate that spot. But yeah, we used to joke about those. They're really good for like tattoo parlors and guys looking cool, but... This is actually...
Or like UFC referees.
Right, right?
Yeah.
But no, I like stuff like this where it makes it really easy for me that even in the middle of the night I might be able to quickly find a wound.